Hi, everyone. Thanks for joining our webinar tonight on prescription drug affordability boards, a new state policy that's trying to lower drug prices. My name is Hussein Lalani. I'm a primary care doctor in Boston at Brigham and Women's Hospital and an instructor of medicine at Harvard Medical School. I'm also a policy researcher studying the prescription drug market for the last few years, and most recently worked at the Program on Regulation, Therapeutics, and Law, or PORTAL, a large multidisciplinary academic research center that tries to understand the prescription drug market using many different types of data. These are my disclosures for today's presentation, and I'll just mention verbally that I was part of the team that provided technical assistance to a number of states, including some that we'll talk about today, on implementing these prescription drug affordability boards. So today, I want to walk you through a few key elements of prescription drug affordability boards and have plenty of time to answer your questions. So this is the roadmap for today's talk. First, we're going to set the table, give you a little bit of background, then talk a little bit more about what prescription drug affordability boards, or PDABs, are, and kind of talk a little bit more about the policy. We'll have a case study that kind of helps us to illustrate some of this as a real example, and then share some resources for you on how you can get engaged. And last but not least, to take your questions. So please do collect your questions and save them for the end, and looking forward to answering those shortly. All right, so just some general background here. In 2022, the US spent about $600 billion on prescription drugs. And as this pertains particularly to states, healthcare is often the number one or number two largest expense for state budgets. So states are spending a large amount of their budgets towards healthcare broadly. And this can include a variety of different things: the Medicaid program, state employee health plans. And within that, prescription drugs are the fastest growing healthcare cost. And so this is why this issue of high prescription drug costs is really, really important to states. And I see Scott having a hard time seeing the slide, and I apologize. The picture was really small, but I've blown it up here for you. And so in Massachusetts, if you take a look at the variety of different healthcare costs from 2019 to 2021, we see here there's physician costs, there's pharmacy costs, there's hospital costs. And when we track these costs over time through the Center for Health Information and Analysis, or CHIA, we find that prescription drugs are the fastest growing healthcare cost of all these other healthcare costs, and they grow at about 9.6% per year. And after accounting for rebates, that's about 7.5%. So much faster than all the other prescription healthcare related costs. So inevitably, this means that something's happening here, and there's an opportunity to try and control some of these costs, perhaps to lower the impact it has on states, and also to help patients access affordable medicines. And so states have a variety of different policies to address high prescription drug costs. And this is just a broad list of potential options. There's transparency laws, there's trying to prevent price gouging, there's laws around pharmacy benefit managers, or PBMs. There's new cost sharing laws. These are things like capping the cost of insulin, for example. And there's laws around prior authorization and utilization management. And today we're going to focus on one specific type of state policy, which is an affordability review, which is a bucket of different policies that allows the state to potentially lower prescription drug spending for certain high drugs, really expensive drugs. And within that, we're going to look specifically at prescription drug affordability boards, which are one type of affordability review. And so what is a PDAB? Well, a PDAB is an independent group of healthcare experts that are appointed by state leaders to review the affordability of certain high-cost prescription drugs. And the state laws vary quite a bit in terms of a few key definitions. For example, which drugs are eligible to be reviewed? How many reviews can a state conduct every year? Can the state set what's called an upper payment limit? And we'll talk a little bit more about that. This is one of the key policy tools that's part of the PDAB, certain PDABs. And as part of a PDAB, this group of independent health experts also has an advisory council that provides them with important diverse opinions of stakeholders across the entire prescription drug market and supply chain. And that includes healthcare providers and hospitals and wholesalers and pharmacy benefit managers and patient groups and other public interest organizations as well. So I want to delve a little bit into the upper payment limit because this is a really key policy tool to understand. So an upper payment limit is the maximum price that a purchaser can pay for a high prescription drug that is deemed to be unaffordable. And this is like the limit that can be paid by insurance companies or by hospitals and clinics purchasing prescription drugs. And this is similar to how states sometimes regulate health insurance premiums and health insurance rates at the state level. And this is an authority that must be granted by the legislature. And so not all states have the ability to set upper payment limits. So that transitions nicely into what is the current landscape of PDABs in the United States. So this is a figure from NASHP, the National Academy of State Health Policy, a really useful resource that convenes states and provides them with policy knowledge and guidance. And we can see here that while the graphic shows us that there's 9 different types of affordability reviews, but there's 7 of those are PDABs. So you can see the states in green are the states that have a PDAB. And for the purpose of this talk, you can sort of exclude New York and Massachusetts. They have a slightly different type of affordability review process that is not a formal PDAB per se. But of the 7 states, so we have Washington, Oregon, Minnesota, Colorado, Maryland, Maine, and New Hampshire, 4 of those states, namely Colorado, Maryland, Washington, and Minnesota, have the ability to set this upper payment limit, that really key policy tool that we talked about. And then 2 other states, specifically Maine and New Hampshire, have what's called they are charged with setting spending targets, which is a completely different type of policy tool that we're not going to talk about today, but it's just something to be aware of. And then, as I mentioned, New York and Massachusetts are a little bit different, and I'm happy to talk about those later in the Q&A if anyone's interested. And the big picture is that the implementation of these types of laws is really in progress. And we're going to talk a little bit more about that now. So let's dive into our case study. So for the purpose of tonight, we're going to use Colorado's PDAB as a case study to understand how this can work in one specific state. Now, Colorado is a state that I helped advise, and it's also a state that is the farthest along in this process. And as a result, it's the one that we can learn perhaps the most from at the moment. So in Colorado, their state law for PDABs, which, by the way, DFA was very supportive of and played a key role in the passage of this law many years ago, I believe around 2018 or 2019. Angie can correct me if I'm wrong here. And so that state law in Colorado has a 4-step process for how to go about selecting drugs and conducting affordability reviews. So we're going to review the 4 steps, which are illustrated in this schematic that's from their website, which I'm happy to share the link to. So the first step is to identify drugs that are eligible for an affordability review. Just to identify the list, and that's using the law, which spells out specific criteria for which drugs may be eligible, and insurance claims data to help process some of those metrics that the law spells out. The second step is to select drugs from that list of the drugs that are eligible for an affordability review. And that involves using the criteria that the law sets out for how to select a drug, and also setting a priority for which criteria are most important. So select and prioritize. And then the third step is conduct an affordability review. And this is a long, complicated process for determining whether just how expensive a drug is, not expensive, how affordable a drug is along the continuum, and a whole host of different factors that may affect that affordability. Things like how much your patient's paying for this, how much is the state paying for this, including a number of other factors that we'll talk about briefly. And then the last step is to determine whether the drug is, quote, unaffordable. So note here that this is an important piece, because we're not saying if the drug is affordable. We're saying, is the drug unaffordable? And it'll be an important distinction to keep in mind. So this is how Colorado's PDAB is set up. And so now let's dive in a little bit more. So step one is to identify eligible prescription drugs. So the original law in Colorado, which has since been modified a little bit, listed these criteria, which I'm not going to read out because they're a little bit complicated to understand. But just keep in mind, these are really expensive brand name drugs, more than $30,000 a year or per course of treatment. And there are a number of other criteria that relate to how quickly the price changes every year. There's also separate criteria for generic drugs. The main one here is that the price of the drug, the list price, which is also known as the wholesale acquisition cost, is more than $100 per 30-day supply. And again, a price increase metric as well. So this is kind of helping to identify which drugs are even eligible in the first place. So Colorado went through this exercise. They developed their rules, which you can view online on their website. They're very transparent about all this. And they utilized their insurance claims databases that they had access to, reported by the payers in the state, on how much certain drugs are being used and how they're being paid for. And they identified, based on these criteria, 604 eligible drugs. And this was done fairly recently, just last year. And this is a screenshot of the dashboard that they created that is publicly available, and that lists the top 10 eligible drugs based on a variety of different factors. But we'll dive in a little bit more about, which specific factors here. But as you can see, there was 604 drugs. And you can see up here, like, it kind of breaks down, like, most of these drugs were really expensive. So the vast majority, 582, were more than $30,000, and these are brand name drugs. So they are on patent. Okay, so the second step now is selecting drugs for an affordability review. So how do we select these drugs? Well, Colorado decided that they identified 17 different factors that one could consider based on the law, and about which drugs to select from this list of 604. And they were pretty thorough about this. And then they went through the process of evaluating the quality of the data and ranking and weighting the factors that are most important. Now, I should say that Colorado has 5 different members on their prescription drug affordability board. This includes includes doctors, pharmacists, hospital executives, and these were all appointed by the governor of Colorado. And so this is a very smart group of people who have expertise in different parts of the healthcare system. And so they went through, and they may not always agree about which criteria to weight, and so which criteria are most important for selecting a drug. So these were the 5 criteria that they sort of prioritized, and you can see them here. This is the total amount that was paid by the state, the average amount that was paid per person per year, the patient out-of-pocket cost, the number of patients that use the drug, and also a metric about how much the price was changing every year. And there was a number of other factors, including a factor on health equity and whether there was a which therapeutic class the drug was in, and the number of therapeutic equivalents or competitors, that were considered and that were reported on. But in the end, these were the criteria that they decided were the most important. And based on that, they then picked 5 drugs that to select for an affordability review. So they decided which factors matter, they looked at the data, and then they made some decisions about which drugs to pick. Now, they didn't just, this is back on step 2 still, but it's listed as step 3. So what they did was they solicited input from patients, from doctors, from scientific and medical experts on this list of drugs. And then they obtained input from the advisory council of stakeholders about the list of drugs. And they had opportunities for public comment. They had an online form that could be completed. They had public meetings that you could speak at. And the staff then compiled a report. Those other factors were initially created to help select a drug. And then once the ranking and weighting exercise was done, the board sort of selected these 5 drugs. And these 5 drugs are Cosentyx, Enbrel, Genvoya, Trikafta, and Stelara. And just to give you a sense, if you may not be familiar with some of these drugs, like for example, Genvoya is a drug that treats HIV. Trikafta is a drug that treats cystic fibrosis. Cosentyx and Stelara treat a variety of different conditions, immunologic conditions, psoriasis, Crohn's disease, those types of things. And Enbrel is a really commonly used drug for many conditions, but including rheumatoid arthritis, which is one of its most popular indications. So after they picked these 5 drugs, now they've started the process of step 3, which is this affordability review. And this is an exhaustive sort of process in which many different considerations are taken about a drug. And on the screen here on the right side is a bucket of different factors that are being considered. So like, whether a drug has any other similar alternatives to it. How accessible is this drug? How much more effective is this drug than other drugs that are available on the market? How much safer is it? Or how much riskier is it to use? What is the price of this drug? What are the rebates associated with this drug? What are the costs to patients? What other regulatory processes should we be thinking of, or are important here? And so there's a number of different factors here that were considered, and a lot of these are also spelled out in the law. So they're not like just created by the board. They're following the law and then making some decisions along the way in a very public process. So they went through this process and they've started to go through this process now for these 5 drugs. So now here's where we are at currently. So now step 4 is we have to determine if the drug is unaffordable. And this is the step 4 of the affordability review process. So far, they've completed 1 of the 5 reviews. That's for the drug Trikafta. And this is a screenshot of the report, which is available online for free. And it is 569 pages. And now this summary report is only 25 pages though. So if you're looking for nighttime reading, just kidding. I do not recommend reading this at night. However, nevertheless, they do walk through a high-level summary of the drug and a whole host of different factors. And now this drug, this process actually played out in a very contentious manner in terms of the engagement that was had with the public, with patient advocacy groups, with disease advocates, with the pharmaceutical industry, and in particular with the pharmaceutical maker, Vertex Pharmaceuticals, which was very upset about this process. And there was a lot of media coverage on this drug, and a lot of it was, I think, unfairly negative. But these are all considerations for the first affordability review that was had. And now, and in the end, the board, after the review was completed, was presented a report by the staff who created this report, with their guidance and with the help of some experts in policy and insurance design and a variety of other things. They had to vote on whether the drug was unaffordable. And they decided that Trikafta was not unaffordable. They didn't say it was affordable. Okay, that's a different thing, although it is kind of like an oxymoron or a double negative, sorry. But they did say that they did not think it was unaffordable. And they based that decision primarily on the fact that a lot of the engagement they had with patients and the public was with people who had access to the drug, who were very much afraid and fearful that they might lose access, which, as we know, is a common tactic of inducing fear into patients that is employed by the pharmaceutical industry. And Trikafta is a very effective drug for many, many patients with cystic fibrosis, and it does change their life in a positive way. And so the board decided that they did not think that this drug needed to proceed to the next step of an upper payment limit, which they do have the authority to set. So now they're going through the same process for two more drugs, Genvoya and Enbrel. And just very recently, a draft of the affordability review was posted to the website, and it will be discussed at an upcoming meeting in a few days by the Colorado Prescription Drug Affordability Board and any public members that choose to attend. And later this year, they will also be completing two more affordability reviews on Cosentyx and Stelara. And this process will continue every single year. And so this is just the first year of this process. And so we're just kind of learning how it happens. But they will be selecting a new set of drugs they will be starting the process over from step one at some point later this year. So now I do want to just share like that, this is a new policy. We don't exactly know how it is going to play out, as is the case with all innovative policies, right? So there are some lingering questions that remain to be seen. And so I kind of have listed some of them here. And this is like, which drugs will be selected by different state PDABs? How will upper payment limits be implemented across the supply chain? What kind of interaction with other federal discounts might take place? And how are rebate agreements going to be impacted by this? And so, we're not going to get into the nitty-gritty of all these questions right now, but if you're interested, I'm happy to talk more about it in the Q&A session. But there are some interesting and unique policy challenges that remain to be seen. And this is going to play out over the next couple months and the next couple years. And there's also changes happening to the laws in Colorado, but also the law in Colorado, but also in other states in terms of how the PDABs are set up. So it is a fluid process. So now we're going to transition into talking about how you can get engaged and learn more about PDABs in your state or in other states. So on the screen is this QR code that directly will take you to the NASHP website and allow you to learn a little bit more about the affordability boards, the prescription drug affordability boards, and it will link you to model legislation that is available on their website. So NASHP has developed a model for what they recommend is a useful way to think about passing a law, a PDAB law, and it's supposed to be a tool that can be used by legislators and advocates and others to try and have a uniform PDAB law that has been vetted by some experts. And so you can learn more about that. You can also use their legislative tracker to understand a variety of different healthcare policies that states are using to lower prescription drug prices, or to try to do that at least. And And if you remember that first figure I showed you, there's some really cool figures, and I'm happy to share my screen in a little bit and kind of walk you through some of those if that's helpful. It's actually a really cool legislative tracker that they have, and it helps you to see what's happening in your state and in other states. Um, and if you happen to live in one of those 7 states that has a PDAB, I really do strongly recommend you to establish contact with them through through the public website, through the public forums, um, and through other means as well. Um, and to get involved if you're interested, because if the physician in perspective, the medical perspective, um, is really valuable. And in fact, it was quite lacking during the Colorado case study, the most recent process. And it's hard to know why exactly that was, but there are many possibilities, including that, well, it's time consuming to do this. And many of the meetings occur during business hours when many physicians are taking care of patients, and so that makes it hard. But there are opportunities to asynchronously provide feedback and input and insight, particularly if you prescribe these drugs or if you have patients who take them, or if you have family or friends who take them as well. And so the medical perspective is incredibly valuable, and I just want to emphasize that it is really, really important to get engaged if you're interested in this work, especially. And you don't have to be like an expert in the policy. You're already an expert in the medicine side of it, and the medical input is the most important part of this process. And as you've learned a lot, hopefully today, and we're going to learn more about it. And there's resources and ways to get assistance from others if you have questions about how to sort of meaningfully contribute to these types of policies.
All right. Well, hearing none, thank you all so much for joining us this evening. And thank you so much for our wonderful speaker. Again, if you are interested in getting involved in Doctors for America, I've dropped my email in the chat. Please feel free to reach out to me, and I'm happy to connect you with some next steps. Otherwise, thank you all so much for joining us this evening, and I will see you very soon. Have a great night.
Thanks. Good night, everyone.